have the distinct pleasure this morning of being your moderator and in being in conversation with Ms. Leslie Pelton and Ms. KellyAnne Pepin from the Institute for Healthcare Improvement. Leslie and KellyAnne bring a wealth of knowledge to today's discussion. Leslie is an outcome-oriented leader who catalyzes innovation in health systems and transforms passion into impactful action. Throughout her 24-year career, she has brought these talents to the improvement of health and healthcare of adults of all ages in the community, healthcare practice, hospital, and nursing home-based care settings. She is a nationally recognized leader in age-friendly health systems movement to improve the health and healthcare of older adults across the U.S. Similarly, KellyAnne Pepin has extensive experience designing and executing programs aimed at improving health and healthcare outcomes, including Pathways to Populations Health, 100 Million Healthier Lives, a learning system for Medicare accountable care organizations, and age-friendly health systems, which will be the focus of today's Global Cafe. Like many of our Global Cafe speakers, Leslie and KellyAnne's passion for their work is truly infectious. And I'm always interested in understanding what it takes to motivate and drive commitment like this, but also the often winding paths taken to get there. I was hoping we could start today's discussion with a little bit about how you both became interested in age-friendly work. KellyAnne, perhaps I could start with you.
Yeah, well, thank you so much. And good morning, good afternoon, good evening to everyone. I'm so excited to chat with you all today and talk about age-friendly health systems. Professionally, my background is in quality improvement and public health, as you were sharing. Before age-friendly health systems, I worked on an initiative called 100 Million Healthier Lives that was aimed at improving health, well-being, and equity by finding innovative ideas and forming cross-sector partnerships. And I really love the work of being a change agent and supporting needing improvements to spread and stick. So I jumped at the opportunity to be involved in improving health and care for older adults at such a large scale. And I suppose my passion for age-friendly work started when I went to college and I joined the healthcare field, and I started hearing terms like the silver tsunami, or phrases that described older persons as a burden in society. And those terms are really shocking to me. How lucky are we to live at a time and a place where we have the potential of living longer, and the older adults in my community are so vital, and my family were so important. I'm so lucky to now live near my parents. I'm so often infuriated by what they experience in healthcare settings. My mom will often describe the way she felt dismissed as she goes in trying to have her health be the best that it can so she can be involved in her volunteer work and with our family and with my toddler. And other times, of course, inspired by the excellent care that she receives. But my parents and the older adults that I know are such assets to their community and to their family, and they really deserve to live joyfully. And I think there's a long way to go, but I'm so grateful to be a part of creating something better. Thanks for asking that.
Thanks so much, Kelly. And I think that's probably a sentiment many of us can share. So lovely to hear. Leslie, we'd love to hear from you as well.
Yes, and thank you so much for inviting us into this conversation. KellyAnne and I are both daughters, so you'll hear about the impact of both of our moms. I think my passion for working particularly with older adults came from my mom's own experience quite some time ago when she went in to get care for back pain, and she was medicated to the point where she couldn't participate in her Monday, Wednesday, Friday walking group and coffee on the bench group, as she calls it. And she couldn't stay awake for her Monday afternoon poetry class. And it was really because her physician, who was actually a geriatrician, didn't stop to ask her about what her priorities were and what mattered to her. She just made an assumption about what my mom needed. And I made an assumption that it must be because we didn't have the knowledge. We didn't know how to, for example, provide comfort to, at this point, my mom, who was about 75, we didn't have the knowledge. Maybe we just didn't have the information. We didn't know how to do this, which seemed a little odd to me because we can send people to the moon. Why can't we help somebody, a grandmother, a mother, participate in society and also have some comfort? But it came to find out through my own research that the knowledge was there. It was just that her doctor wasn't applying it, wasn't using it. And so with my own background in improvement science, quality improvement, change, I started to get really clear in my mind that this was a problem of bringing together the knowledge and the research to the point of care, and that's really where the gap was. And because I'm fascinated by change and transformation, this really locked on for me in my own brain. I came to think, if there's all this knowledge out there and so many populations and people who deserve great care, and there's so many places where there's a gap between what's actually provided. And I thought, if we can solve this, if we can figure out how to connect what we know and what we do more closely with older adults who, as KellyAnne said, deserve this so deeply, right? We're so dependent on older adults in our families and in our communities. We ask a lot, they give a lot, but we could solve this for so many people. That's really what got me very focused on this problem in the care of older adults.
Thanks so much, Leslie. I think you hit on such an interesting point, which is that so often that it's that gap in translating knowledge to action that we fall down in. So I'm really excited to kind of explore how you guys have done that with age-friendly health systems. But before we kind of dig into health systems, despite the fact that age-friendly initiatives and activity have, a relatively broad scope by nature, health systems are often not part of these discussions typically. Can you talk a little bit about what is meant when we refer to health systems, why health systems are important, and how they really fit within an age-friendly context?
So first, I want to acknowledge that all of us spend, thankfully, the majority of our time at home and in our communities. So it's so important for us to be part of the conversation and ensuring that we have age-friendly communities, that we have walkable environments, that we have access to connection with peers, with people of different ages, that we have opportunities to participate in universities and other aspects. So I just want to say the idea of an age-friendly ecosystem, as we talk about it, is essential, and we are completely committed to that. And we think of healthcare, I think of it as like a slice of a pie of an age-friendly ecosystem. And I think of a healthcare system as a place where any of us show up, in this case, an older adult shows up to receive healthcare. It could be a hospital, it could be a clinic, it could be a lot of different places. But the health system is a place where we show up for care. And as we age, we're more likely to interact with health systems. We're more likely to need, at least intermittently, care and to seek that care. And unfortunately, what we know is that too often, not only are older adults not receiving evidence-based care, but are actually harmed when they go into the hospital. It could be it's inadvertent. It doesn't come from a place of not caring for the nurse or the doctor or the social worker. Again, it's this gap between what we know is the right care and what's actually being provided. So too often we know that harm is actually happening. And so we said, if we want to make sure that older adults receive evidence-based care everywhere that they show up for healthcare, we really need to start a movement. We need a way for nurses, for physicians, for social workers, for community workers to know what the right care is, what evidence-based care is for older adults. So we said, let's get really clear on what that is. And let's make it a size that can be adopted by many, many different people in many, many different environments. And so we defined through a pretty rigorous process what we call the 4 Ms. And this is sort of the set of clinical practices that close the gap between the evidence and between what is delivered. So the 4Ms begin with what matters. So what matters to the older adult? Remember, my mom wasn't asked what mattered to her, what her priorities were, that she was just treated for her pain without any awareness of what mattered to her coffee on the bench group, her poetry class. So what matters is that we call it the keys to the kingdom, really understanding the priorities of the individual. The second of the 4Ms is medication. So making sure that medication is responsive to what matters to the adult. Remember, my mom's medication wasn't focused on that. It was focused on the pain, but not on what matters to her. So the second of the 4Ms is medication. The third of the 4Ms is mentation, or the health of the mind. When somebody is in the hospital, we focus on making sure that we're preventing delirium, which is an intermittent cognitive impairment condition. When somebody's in the community, where all of us spend the vast majority of our time, I'm knocking on wood, it is about cognitive impairment and dementia and depression, and making sure that we understand if that's happening. We're providing support to people for whom that is happening, and evidence-based interventions. The fourth of the 4Ms is mobility, making sure that we're able to move every day and act on what matters. So these are all connected. I'm showing them as 4 fingers here, but we're going to put a link in the chat where you're going to see that we have a visual that actually connects them all, because they're all completely interrelated, right? If we don't know what matters to somebody, it's hard to know how to time their medications, what medications to provide to them, what medications to avoid providing to them. It's hard sometimes when we're in the hospital and we're tired. It's very hard for us to get up and move, which we know we need to do to get out of there. But if we know what matters, if a nurse or a social worker or a physician knows what matters, they can help motivate us. I was with my mom last weekend, and she said, don't help me down the stairs because I have to stay in good enough condition to watch my oldest child graduate from college next year. And she just keeps saying that to me over and over again, because she's going to keep moving, because that is what matters to her right now. So these 4 are all very, very much interrelated. With the support of the John A. Hartford Foundation, who are really the visionaries behind the age-friendly health system movement, and our philanthropic supporters, and very much our partners, I want to just say right up front, because we are an international group here, that this has been a US-centered movement. That's where we started, and that is by design, because of that partnership with the John A. Hartford Foundation. And through this work together, we have reached over 3,000 sites of care with the 4Ms, and over 2 million older adults have received care that includes the 4Ms. So the movement has really taken off, and just tying back to your question, Anna, we say that we can't have an age-friendly community without an age-friendly health system, because it is a part of that pie, because we end up there. And when people do end up interacting with our healthcare, we need to make sure that it is evidence-based and safe for them. It was a long answer, and I'm seeing questions come in. I know we're going to get to those.
Yeah, absolutely. No, it was a great answer. It was very comprehensive. And I want to kind of pick up on one of your comments towards the end, which is, I know that the work has been US centric, but there's been some efforts to scale up and do some of that work internationally too. So I wonder if you could speak a little bit to kind of one of the nuance in that, and kind of what that takes to kind of adapt appropriately. And some of your experience in again, what those changes look like, or what some of that thinking and strategizing for that adaptation looked like.
Yeah, I'd love to follow Leslie and speak a little bit about what we've been seeing globally as this work has spread. So as Leslie mentioned, we developed the 4Ms framework and began this work in the US context. And the way we do that, with support from the John A. Hartford Foundation, is we've created guides, toolkits, online learning platforms, community webinars, and they're all freely and equitably available to health systems that want to join. And pretty early on, we started seeing teams from other countries were downloading the resources. They were participating in community webinars, taking the online course about forums care. We were really eager to learn from these healthcare professionals whether the forums framework resonated with them, helped them to meet the needs of the older adults in their communities. And so far, the answer has been yes, that this is a useful framework for health systems outside of the United States. There are now 8 countries. I can list them. There's Australia, Ireland, Lebanon, Portugal, Saudi Arabia, South Korea, and the United Arab Emirates and the US, the 8th, that have a hospital or a healthcare facility that is recognized for being a participant in the age-friendly health system movement. That means that that hospital or that healthcare setting has shared with IHI a clear plan for how they are using the forums framework to assess and act on all of the forums that Leslie described in the care of older adults and in their setting. And there are learners from 45 countries that have completed the online course about age-friendly care. We've now had the opportunity to go through a more formal process with local experts to take on the work of adapting the forums. We've done this in partnership with Safer Care Victoria in Australia and Hamad Medical Corporation in Qatar. And we'll work with them to change some of the implementation and measurement approaches based on the local context, the measures that matter to those health systems. But we've been pleased to see that the forums have remained intact, that a set of care that's based around what matters, that considers the mind and mobility and really looks at safe medication that's dependent on what matters, resonates across cultures and across contexts. So those 2 countries or those 2 organizations in those countries are working on implementing the forums in multiple care locations across their state or their country. And I'll note too that the way that we've worked with US health systems was to hold really tight to the forums. To be an age-friendly health system, you have to work to incorporate all 4 M's in the care of all older adults. But we intentionally left a lot of room for local adaptation because there is a lot of variation in the US healthcare system from state to state, from hospital to hospital. So we weren't prescriptive about the tools or methods used, but we really help health systems to go about planning, testing, and implementing age-friendly care in a way that really considers their unique assets and the characteristics of their local setting. And I think that has set this up to be able to be adapted in different cultures and in different countries in a way that's really exciting. And we'll be eager to keep learning from these countries that have started an age-friendly health systems journey and learning what their results and maybe even the adaptations that they make.
Thanks so much, KellyAnne. I want to kind of pick up on something you said, and it's around just kind of the idea that, one, it's difficult to change systems and you want to provide structure but allow for adaptation. But really it's a question about, often I kind of see healthcare systems, they're often like battleships, and it's very difficult to make change and make movement, and it's a hard ship to turn, so to speak. So what are some of kind of the challenges you've experienced in trying to make change within healthcare systems? What are some of those friction spots, and what have you felt have been helpful strategies in making change in those very big, difficult to change systems?
Do you want me to take this, KellyAnne, or do you want to jump in?
I can start and maybe you can expand, Leslie. I think one approach that we use, IHI, the organization that Leslie and I sit at, is called the Institute for Healthcare Improvement, and we use a method of improvement science. And one thing that we've been able to do with health systems is to use that science to start small, to test their way into age-friendly, to start with one physician, one nurse, one older adult, really use all 4 M's and see the impact that it has, tell that story, start to see the results that providing 4 M's care has, both on the joy and work of the physicians and the nurses and the care providers themselves, and on the older adults that they serve, and build a system around that. And I know there's much more. What would you add, Leslie?
Actually, that was what I was going to say as well. It's the start small. I see some questions in the chat about resources. I would say start small. In one, now I'm thinking about it from the healthcare provider perspective, from a nurse or a physician or a community health worker or social worker. You can put the 4 M's into practice with one person. And all of us as individuals, because, well, I use the 4 M's all the time in the care of all the people that I am connected with through family or other ways, and I bring the 4 M's into those conversations, and it's to start small. It's maybe the first time I go in and have the conversation, I am just going to pause and ask the doctor or the nurse to begin with asking me what matters. Let me tell you what matters, and just start small. Because some of the challenge often, Anna, is that we are overwhelmed. Our healthcare providers are overwhelmed. They're busy, and it can be. I'll give an example. It can be scary to stop a busy day and say, I'm going to take the time to ask this person what matters. Like, what are they going to say? Like, what if they ask for something that I can't do? Like, it's really scary, right? Nobody that I've ever worked with, and I'm not a physician, but has gone to medical school to say, I'm going to sit in this space and be really scared and not know what I'm doing, right? And step into this big unknown. And so I think often it's the fear of how is it going to interrupt my day? Is it going to turn this into a really, really long appointment? And as KellyAnne said, it's starting with one person and seeing what actually happens, and learning how to ask what matters in a way that feels safe and comfortable for you as a provider, and for each of us as individuals to stop and try it out, see what it actually feels like, and learn through that experience.
Thanks so much, Leslie. I think you hit on a good point about the idea that time is limited in healthcare often. So I think it's a really important factor to consider. We've got some great kind of questions already rolling in the chat, so I'm not going to monopolize the question time anymore.
Okay.
First question is from Shmuel, who joins every week, and it's kind of about COVID and what kind of opportunities and challenges that has provided in the context of age-friendly health systems.
I was hoping somebody would ask that question.
There you go,
Like
Shmuel, to the rescue.
KellyAnne, you go.
I'll start again, Leslie, and then invite you.
Yeah.
So this initiative started in 2016, the work of defining the 4 M's, of bringing experts together, and then work to really understand what it meant to implement in health systems, to do a lot of testing. And we were ready to launch, to go to as full scale as we could in 2020. In March 23rd of 2020, we were launching what we call an action community, the big way that we were going to engage many health systems in coming together, learning about the 4 M's, testing together, sharing their learning with one another. And that in the United States, that was, I think, a week or so after we had shut down. And so we thought, nobody's going to come to this webinar. People are too busy. This is an incredibly overwhelming time, as you all know, for all of us, and for older adults, and for folks in the healthcare workforce. And we thought, we will hold to this webinar, and if one person comes to it and we're able to have a conversation about age-friendly care that will be meaningful for us, then it will be worth our time. And there were, I think, 160 people on that call that day. That action community exceeded what we had set as the goal for participants. And it really felt like there was always urgency to improve care for older adults. And COVID-19 has brought a lot of challenges, I will say, in how we've been able to engage professionals from healthcare. But it set the platform on fire. I mean, there was a burning platform for why we needed to do this work now. I think healthcare providers were overwhelmed. We're really seeing the way that older adults were not being served by the healthcare system, and felt that urgency and came to the table. And it was so inspiring to be able to then work together to say, okay, what do we need to do to provide, prioritize the best possible care for older adults? And that group worked together to urgently put into practice different ideas for having virtual visits, for thinking about the safety of older adults, for addressing the isolation that they were seeing now in the nursing homes and in the inpatient wards where they were working. And so again, it's brought a lot of challenges, a lot of strain on healthcare systems. And I like to think too that it's brought some attention and urgency to this work as well, in a way that I'm just so grateful that so many people have stepped up in response to that.
Yeah, absolutely. It shed a rather unflattering but necessary light on a lot of issues, hasn't it? Leslie, would you like to add anything?
No, I'd
KellyAnne
love
got
to
it all
hear
covered.
if there's any follow-up questions to that, but I everything that KellyAnne said, I really underscore, particularly the isolation and what we've learned about that and what we know, the harms that causes to all of us, and that older adults are perhaps most susceptible to that, and the way we can provide care virtually with older adults. I had the opportunity to, we have a physician who is one of our faculty, Dr. Andrea Schwartz, and she was teaching on an age-friendly, with age-friendly healthcare organizations about how to perform an exam virtually. So she took us through a whole video of how she did this in somebody's home, and it was truly phenomenal what she could observe, and how she could connect with the individual in their home. So I think it's really built our confidence about what can be done in terms of providing healthcare while we are at home, if that's where we need to be.
Yeah, absolutely. The digital care aspect is a huge piece that's come in through COVID, so very important as well. Got a great question here from Shuti. Apologies for the pronunciation. Would you like to come forward and ask your question?
Oh, thank you, Anna. Yes, yeah, I think this is a great initiative, and it's truly inspiring and encouraging to see a lot of buy-in. But as the decade of healthy aging is advocating that health is a human right, we do hope that such good and best practice can be adopted by as many as possible healthcare providers within the organization. We would like to see the improvement in the quality of age-friendly care and in the equality to close the gap between different subgroups and different departments. So I would like to know whether 4M's approach, is it adopted by clinical teams of different departments, or usually it would be first adopted by the geriatric team, because older persons are everywhere. Yeah. So do you measure the adoption and the equality, the variation in the healthcare quality for older persons? Thank you so much.
A fantastic question, Shuti. Leslie, do you want to take that first, and we can hand over to KellyAnne to supplement, or other way? Either way.
That sounds great. I'll get us started, I think.
Absolutely.
Shuti, that is such a great question, and I'm gonna. So the answer is yes, that we see the 4Ms being used in many different places, in many different specialties, in hospitals, in clinics, and within a hospital in many different specialties, in oncology, on med surg floors, all the different wards. In fact, Shuti, the 4Ms was originally defined and envisioned not for geriatricians, not for geriatrics, because you said exactly.
They are the experts already. Yeah.
Exactly,
yeah.
right?
Yeah.
We are not in the business of telling geriatricians how to provide better care to older adults, because You said people show up everywhere in the health
Yeah.
system, right?
Yeah.
So
Yeah.
in the United States, if you show up in an emergency department, or maybe Anna, you can help me with translation to other countries.
Can't help too much. I think it's the ER in Canada as well. So we'll rely on my international colleagues to supplement in the chat.
Okay. So supplement help me here in my competency. But if somebody shows up with a sudden heart attack or extreme injury, and they end up in accident and emergency, then we need to be sure that age-friendly care happens there. So we collaborate in the age-friendly health system movement with a geriatric emergency department initiative. And that is to ensure that the 4 M's is happening when somebody is in an emergency department. When somebody is going in for surgery, for an operation, for surgical care, again, help me with the translations, then we know that they are at risk, right? If they're going to be, if anesthesia is going to be used, we want to understand if the mentation, the health of the mind, their ability to mobilize after surgery. So we collaborate with the geriatric surgery initiative of the American College of Surgeons to make sure that the 4 M's are put into practice before surgery, right? That we have a conversation about what matters. We understand medications, the health of the mind, that they're able to mobilize the 4 M's. And so in fact, it is not about geriatricians. It is about making sure that no matter where somebody shows up. Now, the other quick thing, Anna, can I go a little bit deeper into this? Am I okay on time? Okay.
You're great. Go for it.
Stop, Leslie. When you want me to stop talking about this.
I'll raise a flag if necessary.
Raise a flag. That the 4 M's are what we call a framework. So stick with me here for a second. They are not highly prescriptive. We say it was what matters: medication, mentation, and mobility. What we do, because it's a framework, is we leave a lot of space for how those are actually put into practice. So the conversation and asking what matters when somebody shows up in accident and emergency, compared to the what matters conversation that we might have before somebody goes into surgery, we might ask it slightly differently. We might use the information for a slightly different purpose. So the idea of the 4 M's being a framework is to give enough flexibility for it to fit in all the different places that an older adult might show up in a healthcare with a healthcare organization. I want to say too that I recognize that I keep saying older adult, and for many of us, I know in my family and in my community, the older adult is often very, we're very close with a caregiver, a family caregiver. So we can talk about that. But there's other questions on us. So
absolutely, I'll come to the caregiver question because I think it's really important. But I do want to get to some of the questions in the chat first. Francis, I see you have a great question here. Would you like to come forward, and then I'll come to Mark Vetting. But Francis, if you'd like to come forward first, that would be great.
Yes. Can you hear me?
Yes, perfectly.
Okay. I think you partly just answered my question, actually, Leslie, but I just sort of commented and wanted to hear a little more on your 3rd M, which I think is really, I think they're all great, but we hear a lot in the aging community about, cognitive decline and depression and all of that. And I think both the medical community, but also the aging community is very aware of that, but much less so about what happens in hospitals and delirium. And I think this comes as a big shock to people, and they're not well prepared. And I wonder if you could say a little bit more about that end of it.
Francis, thank you for that question. KellyAnne, do you want me to jump into this one? Sorry, I can pause my roll and you can.
Yeah, no, I would love you to answer it. I just want to say first, Francis, I didn't know what delirium was before I started working on age-friendly health systems. And I am so grateful that I have that term and I know what to look for now that I have older adults that I love and have seen them in care settings. But this is just awareness, I think, around delirium is still a big challenge, but Leslie will talk more about in the context of the work.
I was going to say that when I was speaking earlier and I spoke of delirium, Francis, I actually did sort of a mental pause. I thought, is that a term that's going to be familiar? I don't know if you remember, but I even did a very, very non-clinical description, a very high level of what it is, to KellyAnne's point and to your point, Francis, and your great question. I think people are not familiar with it. And we know that it can cause harm, long-term harm. I saw that in my own family, for what it can do to somebody. And it is most often something that shows up in the hospital. It does happen in the community as well. For when we're living at home, it can happen for sure. But honestly, we often see it in the hospital in part because people who are in the hospital tend to be sicker, and that, can be a basis for the delirium, but also we sometimes cause it in the hospital, right? I mean, we say that about 40% in the research that I've seen of delirium is actually preventable. And we've worked closely with a program called the Hospital Elder Life Program. Maybe we can I'll put the link in the chat, because what we found is that the 4 M's are actually very effective for preventing delirium, right? So I have nurses tell me that when they can have a conversation to orient somebody when they're in the hospital, if they know what matters to them, they can have a conversation that orients them and brings them back in time and in place. We know that medications, especially medications that you'll find in the Beers criteria, we'll put the link into that. I'm just making a list of all the things I'm telling you I'm going to put the link in for. And the Beers criteria is a list of medications that we know can put somebody at risk for delirium. Mentation, what we know is that people are not routinely screened and checked for delirium, and that we need to do that in order to know how to treat it. And we also know mobility, that if somebody moves while they're in the hospital and is up and around, they're less likely to develop delirium. So the 4 M's we found are an opportunity to address delirium and prevent those harms that delirium can cause. I want to say too, as a caregiver myself, delirium is a terrifying to witness in our loved ones, and it creates its own harms to us as caregivers as well. So I want to acknowledge that too. So thank you for the question, Francis. Francis, what would you add? Is there anything that I haven't said that in your experience you would add to that?
No, I'm a researcher. I don't work in the medical area, but right at this moment, I'm dealing with a number of friends and family members in hospitals, and I've seen one in particular that every time he goes in the hospital, he comes out with more problems than he went in with, unfortunately. And I see the effects of delirium right now. And I also think that the way emergency wards function is in terms of sleep deprivation, which also contributes to all of this, is a huge negative factor in surviving mentally in hospitals if you're older.
That's a great
that
point.
Sleep angle is super important as well, I think. But another probably a global café's worth of conversation there. Mark, I want to come to your question as well. Would you like to come forward and ask it?
Yeah, Leslie touched on this briefly earlier about telemedicine, virtual care, not to mention direct home care, which is part of healthcare systems. I have a business associate who does telemedicine in the US, and it strikes me that there's a lot of room for improvement there, because you really have to probe and listen a lot more when you're doing that kind of healthcare. So in the age-friendly context, how do we need to make that better?
So it comes to a couple things come to my mind. One is, as I shared, when Dr. Andrea Schwartz was working with us, she was teaching people, nurses, physicians, how to safely and appropriately do all the things that you mentioned, Mark, in addition to being a really good observer of what she was seeing in the home. So we can't assume that our physicians, our nurses, our social workers know how to provide telemedicine. I guess that's my point. We need to provide support and training for actually providing that care. It's just like the rest of us, right? We went from living our lives to, during COVID-19, living our lives online. And there was this period where we thought, well, we could just do everything that we did in our homes and in our communities online through Zoom and Facebook and FaceTime and all of these. But we learned that we had to adjust and actually do things differently over time. And so I think it's really important for us to apply that and think about the 4 M's in a telemedicine environment. We can chat in another link to the 4 M's in telemedicine and actually provide some teaching around that I think any of us as individuals and as family caregivers could also provide to our physicians, our nurses, help guide them in providing this care. So I'll put that resource in. But what I would say, I guess, is we can't assume that it's done easily, that it takes work. The other thing I wanted to say, following up on Francis' question and your question, Mark, is that we're also working with something that we call in the United States hospital at home. So helping older adults who may need hospital level care to stay at home and receive that care at home, where we tend to sleep better. We tend to be able to be closer to the people that we love, the things that matter, the animals that matter to us, the people that matter to us, our familiar photos, all of the things that help, that are about what matter to us and help orient us and so we're doing more around how do we bring the 4 M's into care that is hospital level care, but actually happening at home, where we know people tend to do a little bit better.
Thanks so much, Leslie. I've got a great question here about ageism from Eileen. Eileen, would you like to come forward and ask your question?
Thank you very much, Anna. Leslie and KellyAnne, thank you very much. I like frameworks, because especially because I can tick off the boxes and I say, right, how are you on this, that, and the other? But we're trying to link into the decade of healthy aging. And number 1, we have combating ageism. Where do you bring in ageism when you're introducing the 4 M's? Because when you're talking about older populations, a lot of people would just, or healthcare settings would just isolate you into maybe the over 70s ward. And wouldn't you be better off with the people up there with the golden oldies? So how do you avoid that? Or how do you address that within the 4 M's? Thank you.
Thanks so much, Eileen. Leslie or KellyAnne?
You want me to start, KellyAnne? Okay. I will say, first of all, thank you, Eileen, for the question. It's a wonderful question. And I want to acknowledge that I believe that some of the lack of providing evidence-based care is because of ageism. Delirium, for example, to Francis's question and comment, I can remember hearing my mother-in-law screaming when she was in the hospital, and the nurse saying to me, "Oh, honey, don't worry about it. This happens to all the older adults all the old adults in the hospital." And that's not true. And that is ageism that prevented her from receiving the care that she deserved, that everybody deserves. And so part of this movement is to push through that ageism and say, no, here's the set of care that we know is the evidence and that every older adult deserves. So that's one way I would say it, that by definition, this movement is about, I want to say destroying, breaking down ageism and really taking it on head on by saying, this is what we expect. These 4 M's, we expect this of you, physician, nurse, healthcare organization, A&E, wherever it is. The other thing that I would say is what matters. Remember the keys to the kingdom. When we stop and we ask what matters of an older adult, and we listen and allow space for that person to speak to us and tell us what matters, that also is counteracting ageism, right? Because so much of ageism is about not listening to the voice of older adults. So I also want to say what matters to me is an essential component of combating racism. I said racism, ageism, but actually, I'm glad I said that, because it's really that, we recognize the intersection and intersectionality of ageism and racism. And we, in our work in the United States, are really integrating and looking at the 4 M's by race and ethnicity and asking the question, does it differ? How they're practiced? Are we practicing the 4 M's in a way that is improving the care of people across race and ethnicity? So indeed, ageism and racism, essential parts of the movement, and bringing the 4 M's into practice in a way that really reduces those.
Thanks so much, Leslie. I've got an interesting question here about nutrition in the 4 M's, and I'd love Kathy to come forward and ask that question. And I see Leslie and KellyAnne already smiling, so I assume there's a good answer. Kathy, would you like to come forward and ask a question?
Yes, thank you. I think part of this is coming out of a frustration of what we're seeing as advocates in terms of the quality of food being served in many nursing facilities. It's highly processed, and the residents living in these facilities are really concerned about the steady diet of highly processed food, how that's impacting their health. And I know I don't need to explain to this audience all the connections between diet and physical health, mental health, well-being, what matters. Like food is medicine. I see this fitting under each of the M's. So I'm just curious if you could elaborate how this model, and again, I think it's wonderful, so I hope this isn't taken as a negative in any way, how this is addressed and how it can maybe be lifted up so people get quality, nutritious food, culturally appropriate, etc. Thank you.
Thanks so much, Kathy. Great question. I see KellyAnne, you're on first here.
I'll start and let you finish, Leslie. It's such an important question. And I will say, as our partners and different health systems that are involved in this work have taken on looking at the 4 M's, centering older adults and looking at their needs, nutrition comes up time and time again, and health systems have used the framework in different ways to bring that to the forefront in how they're going about making improvements for older adults. So there are some health systems that have said, you know what, this actually needs to be its own category. We practice 5 M's, and the 5th one is malnutrition. And so we assess for malnutrition in all of our visits and make sure we have a plan in place for addressing that with the older adults that are in our care. And what does that look like in different settings? And so that's an example that we teach, and it's Providence Health System in Oregon in the United States. We're feature them frequently, and they're able to share with other health systems about that model. For others, it's comes up in the context of what matters, and social needs assessments that happen in those conversations, in thinking about it as a part of medication and what an older adult needs for their nutrition. But I think I've heard it less talked about in the context of the food that is being served. And I think that's an incredibly important part. And I'm grateful that you said that, and that that's something we can take back and be thinking about in these conversations.
Thank you so much, KellyAnne. And thank you so much, Kathy, for your question. I have another great question here from Valerie Powell. Valerie, would you like to come forward and ask your question?
Hi.
Morning.
It's almost a way of thinking or a lens, but I found after about 20 years that it was difficult to get staff to look at anything positive. It was always about loss in any assessment. And we had a pieces model, which was physical, intellectual, social, emotional, etc. But the C for capabilities was always empty. And we had to work with our staff to, and this is across Ontario, and it was specifically a behavioral supports program. And under matters, I presume that's where it might fit. But it was always a challenge for us, and I didn't know if that's something you have considered or come across or even thought of.
Thanks so much, Valerie. I think it's a great question about just kind of like the paradigm with which we often, approach older people in their care. So, Leslie or KellyAnne, any initial comments on that?
I was going to say one place, there's probably more to this answer, but one place where I see the forums offering a bit of a shift is in mobility, where within the US, I don't know what it's like other places, the focus has been for many decades on falls and preventing falls, and less on this is actually about helping an older adult or any person mobilize, be active, be able to do the things that matter to them, to be watching for how are they. The assessment that we use is not about falls, it is about mobility, and are they able to walk, and what are the options that they have. And I think that's, again, one example of shifting the focus to be on the older adult and less on the concerns and preferences of the health system. I think what matters is another place too, but I would love to ask some of our clinicians what their experience has been and how that has or has not shifted kind of their mental model.
Thanks so much, KellyAnne. Leslie, anything to add?
I would add that I think what you're raising up, Valerie, I think is a manifestation of ageism. And so, and thank you to Marcus, who chatted in some of the work we're doing around reframing age, some of the work that the Johnny Hartford Foundation is doing. I think of us as we, because we work so closely together, around reframing aging and really shifting the language, the conversation that we're having around aging. And I would encourage you to explore these. We're actually going to do some of this work internally in our organization around reframing aging, because we know ageism is showing up in us too. Like, we may not be aware of the ways that it is. So these are great resources to address it. I wish I had a better answer, Valerie. It hurts me to think of that capabilities box being empty. Like, that is really, I mean, imagine what that does, right, to us. If you see that in your own body, about you and about your loved ones, what that does, how hopeless it leaves you. So thank you for raising that up.
Thanks, Leslie, and thanks, Valerie. I think we have time for one more question, and then I'll give you both time to kind of collect your thoughts for some key takeaways. But my next question, I really want to come back to the caregivers, because as we know, they're an essential part of age-friendly environments and health systems that are often overlooked in the development of associated programs and initiatives. Can you speak a little bit about the role of caregivers within the 4M model?
Essential is what I would say. Just to give a definition, what I sometimes talk about are family caregivers. Really what I mean is are the people who partner with us in our care, whether they are our family, however we define our family, in our villages, in our faith communities, whoever that is that shows up with us, because so many of us can use a partner when we're facing a healthcare organization, a provider, knowing that we might face ageism, knowing that we might not be feeling well when we're entering those conversations and that care. So, you know, we really want to encourage and create space for all of us to show up with a family caregiver. I will say that it can be incredibly helpful for us to bring into our healthcare organizations, whether we are showing up for care or we're providing care for somebody else. A partner can help orient the conversation around the 4 M's, right? That might be very hard for us to do as individuals, but we can do it in partnership with a caregiver. In the United States, there is integrating into the movement the very first step of making sure that our healthcare organizations know who our caregiver is, that we can communicate, that a healthcare organization can communicate with a caregiver, but we have to know who they are first. So we're starting in that super like early step of making sure that we help organizations, healthcare organizations, ask who the caregiver, who the family caregiver is. And then we are trying to find ways for those individuals to have access with the older adults approval to healthcare communications and information, having access to notes so that they can truly partner in the care, and also so you know, when we think about the 4 M's, for example, mentation and the health of the mind. We know how important it can be for a caregiver to share a perspective on what's happening at home, on how somebody is functioning, on observing changes in mood, and to raise that up to a caregiver. So we really see it. I would say a partnership with 2. It can be more than that, but I really see the 4 M's as a circle, an interconnected circle, and on the inside is the older adult and their family caregiver. They are the center. They are the center of the age-friendly health system movement.
Thank you so much, Leslie. As always, we've very quickly approached the hour. So I want to take the opportunity to share the speaker for next week, and also give Leslie and KellyAnne some time to gather their thoughts for some final key takeaways. But next week, please join us for a conversation with Mr. Dan Levitt. We'll be talking about reforming the world of long-term care. So be sure, don't miss that out. Dan is a fantastic colleague, and it'll be another great discussion. So please join us next week as well. So now again, just before we close out, I want to provide the opportunity for Leslie and KellyAnne to just give us one final takeaway message for today before we head off into the weekend. So perhaps I'll start with KellyAnne and then I'll finish with you, Leslie. KellyAnne?
Sure. I just want to share my gratitude for this conversation, and really, we are constantly learning and adapting, and this is not a static movement. So we're going to end this conversation, but we are not going to stop thinking about the questions that you asked, and you will make this movement better because of the questions and the engagement that we had this morning. And I just want to thank you all for that and invite you to peruse some of what Marcus shared in the chat, and then I know will be available on the website. Lots of resources. We say once you hear the 4 M's, you can't unknow them, and so if they serve you in any way, hope you can bring them into your world.
Thanks so much, KellyAnne and Leslie.
Thank you, Anna. Thank you, Luana. Thank you, everybody on this call, for teaching us as you have. And I would encourage you to go out and demand the 4 M's for you and your loved ones and your healthcare organization. And we're here as partners if there's anything we can do to support you.
Thank you so much, Leslie. And just to reiterate, thank you everyone for joining us this morning. It was a pleasure as always, and we look forward to future discussions. Thank you, Leslie. Thank you, KellyAnne. Have a wonderful day, everybody, and have a wonderful weekend. Thanks so much.